I like the story in general, specifically, how she gives, how she gives the medical students an assignment, or whoever was it, her residents. She gives her residents an assignment, and I feel like you kind of sometimes you have to give yourself the assignment, to do it. Otherwise, you won't do it. I was in the education retreat, and there was a session that I went to on maintaining positivity and on gratitude, and the idea that we would have to actually assign ourselves, things to look for in gratitude, things to be mindful about. And I know a lot of your writings that I worked with this time were about mindfulness, things like that. So I encourage you to give yourself assignments to help your curiosity. Any other thoughts about the reading? Yeah.
I thought it was interesting how they broke it down in one of the last paragraphs of like how does the patient benefit from curiosity and then how does the physician benefit?
Yeah. How does the patient benefit from your curiosity and how does the physician benefit? In your own experience, how do you think that you benefit from that in terms of your relationship with patients?
I think part of the curiosity for me is not just, I wonder what diagnosis they have, but I wonder what they could, or like what led to this. For example, if they have like high blood pressure, and say, oh yeah, well, like weight and some of those other things in their diet, but I wonder where they're coming from. Like I wonder more about like a holistic view of it. And I always think that's interesting about getting to know people, which kind of made me want to do science, but I'm more drawn to other things, but I still appreciate looking a little bit into it.
I think that's the thing, yeah.
Atul Gawande in his book Better, he says, he gives like 5 admonitions at the end. I can't remember all of them, how they go, but he says, ask a question. And then he goes on to expand on this, and it's really in line with this. And not just asking one question, but really asking a sequence of questions. And what he points out and encourages is more than just asking your patient, but when you think you're on all these rotations and you're sitting in somebody's office and you're sitting next to that, physician assistant or the person, just, to ask them, who are they and how did they get here? And asking a couple questions, you just find things out about people that are just totally mind-blowing. And there's a patient care assistant in our department. The first time I sat down and I talked to him, he asked me where I was going, and I said we were going downtown and we were going to try to donate some clothes to this concern that gives people clothes when they go out on an interview. And within 5 minutes, he told me that that's how he got his job. And he went down there and he got a suit. And this is his gateway into a working life. It's like we're like best buddies. And if I wouldn't have had this little conversation, curiosity.
Excellent. So that says it better than I could. Do me a favor. So we're passing around candy. Do me a favor, like we do in the theater. If you're going to have candy and cough drops and things like that, could you unwrap it before we start, please? Silence your cell phones. And we have our 3 actors back. I don't know if these were our actors with you guys or not, but can you guys reintroduce yourselves?
Hi, I'm Colleen Longshaw.
I'm Jim Lally. Chris Bohan.
And I'm Catherine Burke. And let me turn off my cell phone. Okay. We'll give you guys just a second to get your candy and unwrap it. Oh yeah. Come on. Stop. All right, are we good?
I'm good.
We good to go?
Everybody unwrapped?
Are we all done unwrapping?
All right.
I am so excited for medical school to begin!
I want to get involved in the translation of scientific discovery to progress and benefits in patient care with the ultimate goal of finding a cure for certain diseases.
I want to experience within the system.
I don't know what to expect. I stand before the white door, outlined in the white wall. I take a pause.
I'm excited to see how a hospital is run.
Dissatisfaction with the status quo provides motivation and underlying driving force for innovation.
I take a deep breath. In for 5 seconds, hold for 5 seconds, exhale for 5 seconds.
Anxiety knocks on my door.
My very first longitudinal clinic session.
This patient used to work as a nurse. Several years ago, she met her then boyfriend, who was a drug addict. Very soon, she also started using drugs and eventually lost her job. Recently, they were engaged, but her fiance then died due to overdose, and she lived alone. She's tried to get clean several times, but always relapses soon after. She frequently showed up in my clinic complaining of chronic pain, but all her imaging studies were normal, and there was really no evidence of where her pain came from. The reason for her visit today is foot pain.
We enter the room. How are you doing?
This pain is so bad. Nothing over the counter is working. I tried some of my sister's Percocet though, and it worked. I think I need a prescription. It's really the only thing that works.
We do a thorough exam. Her foot looked normal without any gross motor or sensory deficiencies.
We could do an x-ray, we could do some non-opioid analgesics. I'll evaluate your pain based on the results.
No, that is not what I need. You don't care about me at all.
She went to take the x-ray. Later that afternoon, just before we ended the clinic,
Turns out, indeed, she had a small stress fracture in her foot.
before I met the patient, I already formed the image of a drug seeker in my mind. I was treating her description of the pain just as a story she made up.
A 43-year-old female patient's room. I am so glad I am not involved in the care of this patient. Multiple substance abuse. Hello, I'm a medical student. I'm here to observe the direct scope procedure by the ENT.
Oh, what's an ENT? A technician?
No, surgeon. She doesn't seem to understand. I'm not surprised after the procedure.
Which year of medical school are you?
Third year.
How many years do you have? What specialty are you interested in?
She is the first patient in my entire surgery rotation who had ever asked about me, more than certain faculty and residents had ever cared to ask. She deserves a few minutes of my time. I'm facing my own bias. Despite the undelightful history, this patient is a nice person who cares about people. I shouldn't have been against her from the very beginning.
The medical student-nurse relationship. I make a concerted effort to be respectful to anyone I work with on the team. Nurses, residents, nursing students. Unfortunately, my efforts are not always reciprocated. I have found it particularly difficult to build a good working relationship with nurses. My questions are dismissed, or I'm met with skepticism. I want to be more directly involved in helping a patient push during active labor. I'm literally pushed aside and made to stand basically in the corner of the room. Why am I having such a difficult time ingratiating myself with the entire team?
They think medical students are dumb. I'm sorry. They don't see you as valuable members of the team. So when you try to help, there's a level of distrust.
Well, I can't say I'm surprised.
What I have perceived as a well-oiled machine is much more a system of humans trying their best.
I'm frustrated. The system is not perfect.
They're fighting all the recommendations.
I need to round.
The system is not.
Lost in the shuffle.
A breakdown in communication.
A nurse made a huge mistake.
I was halfway down the hall before remembering that I should have checked.
I did not meet my own expectations.
Not perfect.
I could feel my heart rate
My
rise.
muscles tense.
My posture shift, ready to make a run for the door.
Second year.
A patient comes in with a black cane topped with a skull, wearing all black and a top hat. He's seething with anger. How are you feeling?
I'm in pain. I've been everywhere and I'm just not able to get the pain medication I want.
He proceeded to,
Swear,
and
complain vehemently.
about the delay in his treatment. Interspersed, he would add,
Personal attacks and insults.
about the medical profession. This was the first time I had met such a difficult patient.
And another thing.
Frustration just boiled up in me. I had to stay silent to present myself or say anything without first thinking about how it would affect the conversation. Slow. I know how you feel. I had a facial fracture once and the pain was terrible. You know our role is to provide you with the best care possible, and we won't do anything to cause you any harm. It worked.
A group of students and preceptor are visiting patients in the hospital who have interesting diagnoses and physical exam findings. We are sitting along the edges of her room, listening to her tell her story. We are interrupted by a consulting attending and a resident.
Can we speak with you?
Sure.
They go on to tell her about
Radiography findings that are suspicious of lung cancer or metastasis, so the next step is to do a biopsy.
They talk about other things that I don't fully understand. I feel uncomfortable. We are intruding. The patient tried to play it off lightly, making jokes. No one had asked her if it was okay for 5 strangers to be in the room with her. After the attending and the resident leave, we continue with our physical exam, listening to the crackles in her lung, as if none of this had ever happened.
Afternoon clinic. Just finishing seeing our last patient. My staff helped me formulate a learning objective that I would lead and go research and do my evaluation with my findings later on that night. Where should I report tomorrow? You forgot to include me on the schedule.
Figure it out. I don't have time to babysit you.
Have I done something wrong? Why don't the residents say anything? What kind of person would think that that type of behavior is acceptable?
I will never allow myself to become that kind of physician, one who does not care or foster an environment of respect and professionalism.
And I will never let my residents behave in such a way either.
I will make it a point to make sure that my residents foster a respectful learning and working environment with their interactions with everyone. Students, nurses, technicians.
And if not, they're gonna have to answer to me.
A 76-year-old cantankerous gentleman. Every time I pass by his room, I find his nerves either entering or exiting with a look of frustration and annoyance that is unmistakable. Every hour, almost to the minute, the patient cries out in excruciating pain due to his bladder spasms, demanding attention. No one in the room is safe from insult or demeaning comment during one of these spasms, not even the patient's family. He has been difficult to deal with throughout his stay. We know that his pain is caused by spasm and that while the discomfort might be very real, it is in no way an emergency. Nonetheless, every hour...
Where is the doctor? This is an emergency! Can't you see that I'm in pain? Do something! This is an emergency!
Another routine, oxycodone, belladonna, and opium suppositories, and another dose of oxybutynin. I tried.
Get it right, doctor!
I'm a medical student. But rather than simply relay the same information, I simply stood there.
Can't you see that I'm in pain?
Yes, I can. What would you like me to do? He hadn't expected my response. Giving him some control over his care calmed him down. The spasm ended and the obscenity subsided. I later went back to speak with him while he was resting comfortably in bed. What would you like us to do when you have another spasm?
Just some attention.
He wanted to be reassured that his pain was not an emergency. After that, the patient and his family would ask for me by name when he was suffering a spasm. I would go and sit with him, and he would be at least somewhat relieved by my presence, by my attention.
This test has dominated my life for the last 2 months. Fuck, I'm tired! My head. It's over. It's over. I just hope my score will reflect all of the hard work I put in. And what was that question about innervation to the outer thigh? I still can't believe how bad I was at the auscultation questions.
The only Italian phrase I know off the top of my head is "Pace, pace mio dolce tesoro, il cane di la voce t'adoro," which is the opening to a short aria sung by Figaro in the Marriage of Figaro by Mozart. She probably doesn't want to hear that. The little old Italian woman is kissing a set of rosary beads and a cross around her neck, clearly devastated by the state of her catatonic daughter who had been rushed to the emergency department. We helplessly watch a parade of people asking questions, putting on leads, and mobilizing the daughter to the CT scan. I try to pay attention to what's happening around me, learning how the hospital mobilizes in this acute setting. And it dawns on me that I am learning about another side of care that is equally important.
Mr. X lay in his hospital bed, unable to really move on his own and unable to communicate effectively due to a stroke and him not having access to his dentures. This is the second week in a row that I've woken him at about 5:30 a.m. to check in on him before rounds. I'm not sure if he likes me very much at this point. I am sorry, Mr. X. I can't understand you. Please try again, and I will listen really hard. Mr. X, I know you're trying to tell me something, and I'm so sorry that I can't understand you. This must be very frustrating for you. Let me ask you some questions to try to figure out what you want. Do you have any pain? Are you hungry? Are you thirsty? I understand that you're thirsty again this morning, but I still can't let you drink any water. We're afraid that your stomach still hasn't recovered from surgery, and that if we let you drink water, it'll end up in your lungs and you'll get pneumonia. And we're afraid of that happening because we don't know if your body can handle it. Let me get you some more of those citrus sticks to help you with your dry mouth. I'll see you in 30 minutes with the rest of the team. A few days later, Mr. X is doing much better, and he has regained the ability to say a few words, albeit with great effort. And I sit and I talk with his daughter for about a half an hour, and she tells me stories about Mr. X and his life before he got sick.
His business efforts, and how he fought in the war, and his love for his family and his family history.
Thank you for sharing that with me.
You're a good person.
Apparently waking up at 4 a.m. so that I could get to the hospital and look after Mr. X's new labs and vitals every morning before waking him up and talking with him for 5 minutes was actually more than an exercise in inhumane treatment of medical students. Those mornings were important to Mr. X. Now they're important to me as well.
A 19-year-old male brought in by EMS after he reportedly tried to do a backflip in a bouncy house and landed on his head and neck. He had no family, no friends, nobody was with him. The teams crowded into the trauma room, discussing his care and which team he would be admitted to without directly speaking to him. We didn't know the patient's identity, and when people would ask him a simple question, "What is your name?" the patient didn't respond, even though his eyes were open.
I don't think he speaks English.
But he has a tattoo written in English. Patient is taken into a room for an x-ray while we're waiting. Hi. How are you doing?
I'm scared.
I was surprised to hear him speak. I suddenly felt very scared with him, as if I were in his position, alone and terrified. He was a young guy, surrounded by large groups of strangers, throwing him on words like spinal cord injury, neurological damage. Listen, I know it must be very scary. I'm sorry this has happened. We're going to take care of you. Be here.
Okay.
In the medical breast clinic at the Beechwood Breast Center, I went to see an 80-year-old lady following up after a prior visit related to breast pain. And this lady was one of the sweetest patients I have ever seen. She was so happy and willing to talk with a medical student. The family history is very important in the breast clinic when assessing breast cancer risk. I saw mention of her parents and her grandparents as cause of death in the note from her last visit, but it did not say or mention her children's health. Do you have any children?
I have 2 children left, 2 are passed on, 6 grandchildren.
Would you mind telling me what happened to your children, how they died?
Oh, it was so sad. My youngest son died of croup when he was just 6 years old. He'd been prone to infections his whole life, and one day he was ill, and so I asked my husband to stay home with him so I could go to work. And though I usually like to be the one to stay home with my son. And later that day, I got a call at work, and I had to go home, and when I arrived, my son had passed away. My husband just couldn't accept it. He called an ambulance anyway. I just cried. And my daughter, well, she died of a heart attack when she was just 30 years old.
So sorry to hear that. Life is it's too short.
A patient with a complicated history and clinical course. He is a 40-year-old male with a 5-year history of ventral hernia repaired with mesh, which subsequently became infected and necrotic, was removed, grafted, became necrotic, and grafted again. Post-op, he is constantly febrile, his white count consistently above 50, and he has to remain in the beach chair position for weeks while poked and prodded by his various surgical teams while a cause for the elevated white count is searched for. This entire time, he has the most positive spirit.
Hey, how are you today?
With a realistic understanding of his current conditions and risk. The whole team is constantly rooting for his recovery. One morning, a night after retching leads to dehiscence of his graft and evisceration. We see him first thing in the morning for rounds and arrange to have his wound managed in OR within the hour. When we speak to him that morning, however, it is the first time we see his spirit waver.
You know, I'm really not sure that all this struggling to try and help me is really helping me. No matter what happens, I was able to get to another 5 years with my wife and kids that I would never have had before that.
Don't give up hope. We'll take care of you. But I'm shocked by his words, seeing the crack in his armor, witnessing his struggle, preparing himself for death. I never truly considered that he might survive. I feel like I'm going to cry. I'm surprised by how blindsided I am with that feeling.
I'm observing.
I have some news for you. It's possible your wife could have Creutzfeldt-Jakob disease. It's a terminal illness. So that's the worst case scenario. But it could also be a couple of other things we have interventions for. Based on what I'm seeing, it seems most likely that she has CJD.
She goes on to explain the terror that is CJD and how rapid it acts, how...
There is no treatment and only months of life left in most situations. I hope it is one of the other possible diagnoses.
I recall that these diagnoses would be horrifying in their own way to the average patient.
We will hope for a better prognosis until the final results come back.
How would you want the doctor to break the news to you?
I would want honesty, simplicity, and an offer to follow up shortly after so I have time to process the information.
Who would you want to be there?
I think I want to be alone.
What would be helpful to you in such a moment?
Empathy. I would just want a thoughtful conversation and the feeling that the person was truly doing all they could to help.
Bombs away. Don't tell me in the middle of rounds. Please don't rush away. I might demand you leave, but be prepared to stay. There will be so many questions. Perhaps not right away.
Chemo, radiation, the works, a colossal dagwood of care. I'll probably want it all because damn am I young, and my yearning towers tall.
No facts and figures just yet. Don't gush out all the options of care. Let me be the one to ask, or let your mama bear if she's there. Her plan of attack will be a mighty force. But for now, let us drift in this moment. We just learned about the storm. Let's soak in its enormity before we hear your voice.
Prepare to be unprepared. Vesuvian rage. Vacant disbelief. Crushing despair. I may be just one, I may be all. No way to know which until right then and there. Dropping a bomb brings the urge to flee. Detonate, but sit it out. Embrace this chaos for me.
He is a big guy, has to be 400 pounds. His belly jiggles as I compress his chest. It seems so surreal. I've dreamed of doing this since I was 14. All those days spent volunteering in the ED, working in emergency admissions, working as a high school intern in the clinic's ED, countless 911 runs with EMS, all those nights spent watching emergency medicine TV shows, marveling at how seamless the team's function seemed to be despite the surrounding chaos, and with the all-powerful ED physician at the helm, calling the shots that literally walk the line between life and death. To me, it symbolizes the epitome of the jack of all trades being the last man standing between someone's life and death, with only intellect, skill, and leadership to rely on. And here I am, pumping away. No cameras, no crying family, no panic. I looked at the clock to time out my compressions, expecting the seconds to fly by. Tick, tock, tick, tock. They feel like normal seconds, just ordinary seconds. Even though they'd be this patient's last seconds, I think I'd hear his ribs crack. I think I'll get a pat on the back for doing the world's best compressions. I think there will be this miraculous moment where either the patient comes back or just starts bleeding out of every orifice or defecating or peeing or something. Anything. But it seems like an ordinary moment. I wonder who he was. Why I can't see his eyes. And then we call it. That's it. And the physicians quickly foam out and go to check in on their next patient.
The husband came over to me emotional, saying the surgeon saved her life in the operation.
She began to cry and remarked that no one had ever taken the time to address her and her concerns at length before.
I nodded my head. I squeezed his arm.
And he was so thankful for our assistance.
The patient expressed his gratitude for my having listened to her, as the thing he is most concerned about is not himself.
He nodded his head back, acknowledging I had feared him, and fell asleep exhausted.
But how his wife has been struggling with his illness.
The hospital at night is a magical place.
Empty, quiet hallways, fluorescent lighting dimmed, the lens of fatigue that the
Robots,
Quietly whir and beep, restocking supplies depleted during the day.
non-essential personnel go home, which means just about everyone.
it's more efficient.
More productive.
More caring.
Everyone who's here needs to be here.
That's it.
Aw, that's it. You can stop. Thank you. So now we have the dialogue, and I'd like actually, so I've been immersed in this for several days now. So I'll be Dr. Cohn. I spent too much time with Dr. Cohn. Okay. So what do you think? What do you think? Thought? You can hear your own stuff? Yes.
I heard that
cupcakes.
That's all you want. Pass the cupcakes, yeah.
So, I thought it was great. I guess it was a good job. I think what struck me the most was like how, like some of it was like absurd, it was like flowery, like we're writing these things, and I guess like thinking like how introspective a lot of it was, and thinking of how much more introspective I was the first couple months of third year. And then as you hear the things go on, the story goes on, like all of us have probably had patients just like that. And I feel like at the end of third year, like I remember there was like one that was like a chronic pain one or whatever, and kind of just like I don't even, it's just like it's another patient. You kind of go into their room, not thinking about like, oh, I didn't listen to the complaint or something like that, you know. So I don't know if that's like bad on me, but that's the thing I got the most out of that. Finding myself less introspective, unless it like really stands out. The farther I go along, it'll be a reminder of people more introspective.
It was really cool to see kind of that transition, or just a mix of earlier in the year, second year, and then in the third year. And just kind of what Joshua was saying as well, just keeping that curiosity, which I think is kind of the tide that you're doing with this. Just remembering how it is from the patient's perspective, how we felt before, and then making sure that we keep that perspective as we go forward.
Taking your own pulse first sometimes. Just, what's the novel?
How's it going?
House of God, thank you. Yeah.
That was interesting that even some of the patients that were not my personal patients, like the hernia patient, I was like, that's a team Steiner patient. No, it's a Steiner patient, if I hear one. And knowing like who else was also, and that was the team I was on, that I talked about before. And just hearing other classmates who've been involved. And I know that personally, I've had patients who are like, oh, I know that you saw this patient as well, and kind of hearing that from the state is kind of fun. Remember that, we're all kind of, even on different teams, with very different experiences, we're still involved with similar patients' care, even the same patient.
Thinking in sort of maybe as a flip side of what Joshua and Aaron were saying, it's interesting to see. It is interesting to see how, I guess, maybe more reflective or more concerned with some of the emotional aspects of patients, personal interaction with the teams and stuff. That was more on the early end of things, and even now, I think. Hearing some of the stories automatically in my head went to what's going on with that patient, what medically is going on, what's the backstory, what's the problem, even though this is in the context of a play about reflection, that kind of thing. So I wonder if there's some, going through third year and gaining some level of, if not confidence, at least comfort in these kinds of scenarios, and getting them to move on from that first knock on the door being intimidating to now thinking, okay, so where can I sit, what's going on, like what's my differential, what am I doing for this patient medically, and sort of transition to that as well.
Yeah, so I get to do this 4 times a year, 3 in the first year, and once for you guys in third year, right? And it's a striking difference, and you guys have done all 4 this year, it's a striking difference between the first one that we do in the first year and this one. I mean, the content is not only the content is different, but the way in which you guys write about it is very different. Even in the first year, the way the transition from the first one to the last one is very different. I wonder if you guys
Oh,
noticed
yeah, I apologize. I wasn't able to read that last line because I was weeping.
Yeah, I got weepy too.
It's interesting to see, because you guys are in the middle now. Reading from when we do the first years, it's this, how are the patients going to see me? How are the doctors going to see me? What does it mean to have this code? It's like that whole, freshman in high school feel. And then you guys are on both sides. You're like, these patients, these mean nurses. Like, it's in the middle. They'll respect us one day versus, I hope I can what I want to be when I grow up. They'll respect me. You know, it's like, it's very interesting. It really, really is. And I'm like, I wonder if they remember when they were like, oh, white coat. Like, it's super cool to watch the process. And then to imagine then where you'll be 2 years from now. And especially now, I'm gonna make sure my residents, blah, 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 blah. I was like, get them together, girl. You know? And it's just really cool. It's really, you guys, yeah, it's cool. Yeah.
Can I ask why you're so emotional? Like, what about reading?
From the reading.
Okay.
I got,
Interacting with the patient, I just went there. Happens.
actors are very emotional people. No, it's true. You know,
It's true.
and I got taken by surprise that I
It took
got.
me by surprise.
Yeah,
That's-
I could see it happen. And I got taken by surprise with the little old lady in the, yeah.
Oh,
I got to tell the story about her 6-year-old who died, you know. That's it. I didn't cry until I did it in front of you guys, so.
me too. And I wonder if, is it against the rules to be emotional in a room? No? Right.
To tell that lady about that disease I can't say, Crohn's that, yeah, hey. To do that one, it was very difficult, and I felt myself thinking, I don't know that I could deliver this kind of information every day and
Yeah.
not cry. And I don't know if that's just because I'm so in touch with my feelings. And then, because as an actor, you need to have access to them, you know, and I don't know if I had that level of access all the time. I have to have it, but I teach children all the time. So they tell me, I'm told awful things. I mean, I called 6x6 kids twice this week. So in that scenario, I have to pull back that emotional covering and I can't let them see it. But as an actor, I have to have direct access to it. And I don't know how delivering that news to people, that kind of news to people. I know when a couple months ago, they found a lump in my mom and she had to have a biopsy. And her trying to tell us what the doctor told her, she could barely do it, you know, and then us going with her and being the family in the room. So all of this is touching in a way because you, as the people outside of, well, without the cloak, you know, you experience it from that angle, and the fear is real, and you do start to spill. I leave the doctor's office like, I'm sure she did not want all that information about me. But that's that level of vulnerability in that room. I'm spilling things to her that I don't need to tell her. But you just feel like she's gonna help me live or die, so I better tell her that I eat too much popcorn. You know what I mean? Like that. So it's very right there. You're very close to it. So it's an emotional thing to hear because these are people we encounter every day. You know, go to work and somebody's there and the next day they're gone. And because of conversations they have in rooms with people with white coats. Changes your whole life and the lives of the people around you. So it's emotional. That's why we watch so much ER and that kind of stuff. That's why that kind of TV is so popular. Every week it's a new Cleveland Clinic, you know, emergency room, TV show. You know, because people watch that. It touches you.
In the back.
No, I mean, just kind of like building off that, I've recently noticed like the opposite issue where I feel like I've gone into patients' rooms and like there's no reason that you can't be emotional, but like if you're delivering bad news and you just start crying,
Right.
like it's gonna tell them like there's no hope, like be really sad. Like, sometimes it's okay that people like want to be hopeful even in the face of, you know, an insurmountable, you know, task or something or illness. So you have to, I mean, like reading the room, it's almost like you don't get to choose, you don't get to interpret the character and create, you have to be what they want you to be, basically.
Right.
And so what I've realized recently is, you know, like I feel like going into medical school, I was able to really, when I went into, if I had a friend who was sick or something, I'd go in and I'd really, like, be able to be really emotional with them and whatnot. And then with medical school, I'm now mirroring, and I've realized that a lot of patients want the, like, especially initially want the expert, and then they want empathy, you know, along with it, but they really want to also get the information. They don't just want, a lot of times want to sit there. So I've had a friend recently who was just, you know, diagnosed with a really serious illness. You know, life survival less than 2 years, you know, one of these things. And I found it actually really difficult to decide even if I should be in the friend role and go in and be really emotional with them and whatnot, or if they wanted me in like this like they don't know many people in the medical field, and I would never give them medical advice, and they're in a hospital, so they have their doctors, but they also have a lot of questions they can't ask the doctors, and I didn't know, so should I treat this as like the, oh, let me like explain what's going on to you and try to be as neutral as possible while providing some hope, but not too much hope, you know, and saying, well, I don't want to give you that information yet because we don't have all the tests, and I don't want to like give you wrong information, or do I kind of like be the friend who's there and say, no, we're gonna like get through this, let's be hopeful, let's whatever. And so I don't know, I kind of, you saying that switching between the roles is something that you have to do as a mother and an actress, and then, you know, it's like an actor like becoming the part and being able to be emotional, and knowing, you know, like when to pop into that and when to hold back a little bit. I've realized that actually it was only starting third year that I've had this trouble of knowing like when should I pop into like the really like the friend mode, the hopeful mode, the more I'll call it the more emotional mode, and when do I have to play the let me mirror what emotion do you need me to mirror, let me be the deliverer of information in an empathetic way mode. And that's something that popped in, that's something that I didn't have to really deal with first and second year. I guess with knowledge has come that, for some knowledge has come that kind of that own parallel experience.
Yep. So it's kind of interesting seeing this. So last Sunday, I had one of my last shifts in the emergency department, and I was talking to my wife when I got home, and I just thought, you know, it's kind of interesting. You know, like I see people die, like another person died that day, and it's just weird that's not, like that thing with that evil spirit doesn't affect me as much as it used to, because it was like really hard for me, like when my nephew died, for example, and even though I'm really religious and everything, I just thought, you know, that's interesting. But then yesterday, I had a morning clinic somewhere, and then I had to stop by to let my dogs out on the way to my other clinic, and I saw all these cars at my neighbor's house, a few houses down. Sorry, this isn't letting me get out. And so I saw it said estate sale there, and I haven't been able to talk to her for a while. She's kind of like one of the older, like social recluse women, and it's like one of her only friends. I go help her with stuff, and she'd go like whistling, like a cardinal would come down to her hand and like eat out of her hand and things like that. And so I just stopped in there and asked, like, Christine passed away? And they said, yeah, she did. And it was really kind of shocking, kind of showed me, you know, like, it really does still affect me. And so I was able to, people said, oh, you knew Christine? I said, yeah. And so I was able to talk about her a little bit, and everyone just really appreciated it. And like, she'd always ask me for medical advice, and I'd always have to tell her, you know, I'm not a full doctor. But yes, I do think that like a shot of hyaluronic acid and cortisone shot, that's it. And you know, like sometimes you need replacements, you should listen to your doctor on that. You know, but other things. But and the other thing, part of the thing that really affected me is I just thought, I wish I would have known when she were at a dying. I wish I could have done something else. Whereas in the hospital, you know, their protocol, everything's controlled. Right. You see that. But even though, just thinking about it medically, he most likely died from a heart attack. And so there wasn't anything I could do. And I think I was probably in labor and delivery when she passed away. So it's just kind of like that. It re-exposed me to that feeling of helplessness, just kind of wishing, I wish I could have done more, like, what I had done. So that's kind of like a interesting turnaround that they came around so quickly, and then we talked about it today, but you know, overall it's very good to see that again.
So your heart's not turning to stone.
No.
Sorry, you lost your friend.
You know, I want to add, first of all, you guys are always blowing me away with this stuff. And I get emotional just watching you do this, so it's great.
Me too.
This is such a perfect ending for this course. This is really what this is what it's all about. So you know, you have this disease thing that, you know, some pathophysiology thing, you guys know this stuff, cold. And then you have a patient come in, they have these signs and symptoms, and you ascribe some kind of name to it. And then, I don't know, maybe you use this term, you said read the room. And this is the reading the room. And so there's this other dimension. You know, Eric Cassell says, you know, diagnosis, treatment, symptoms, And then there's the people. And the people are all different. They're like crazy different, you know, and sometimes they're like, you know, give me the facts. Sometimes it's, you know, let me rip my spleen out in front of you. And this is what the art of medicine is. This is really what the art of medicine, and it can't be packaged, and it's not an algorithm, and it's being in touch with yourself and being reflective, and, you know, just to have this opportunity to do this with people like this and kind of listen to you, your own voices, and all this medicine and the raw stuff. I mean, this is just, if you can take this with you, you'll always be in touch. So this is just fabulous. Thank you so much.
Thanks,
Thank
you
you
guys.
guys for this.